Welcome everybody back to my channel. Today we are talking to Dr. Patrick Lockwood, and I have been enjoying watching his Saturday podcasts on YouTube. He talks a lot about mental health. I think he's kind of a middle of the road character, and he might not agree with me on that, but he kind of is critical and safe at the same time, which actually is approachable to me. So if we don't agree on every single thing,
Sure.
this conversation is definitely more for me than it is for my audience, because I just enjoy his mind, his intelligence, his thoughts, his ideas. And I often think about the same things that he talks about. And I like giving him trouble on his podcast. So maybe he will give me trouble
Yes.
today. But
Heck
I think
yes.
this will be, and I welcome arguing and disputes, because I think that's where the growth happens. So
Yeah.
I hope you can change my mind about something today. We'll see. But welcome
We'll
everybody.
see.
And yeah. So first, can you tell them who you are in case they don't know?
Sure. Yeah, and thank you very much for letting me come chat and play around because I love this kind of thing and I don't think it happens enough, honestly, sincerely. So I'm very happy to be here for sure. I think, one simple way to think about me is I'm kind of a turducken of a person. So I have essentially three lives that I live. A third of my life is being a professor teaching future master's and doctorate level clinicians. And I've been doing that for 9 years, I believe. And then I have the other third of my life doing primary clinical work. Most of my clinical work is at a sleep clinic, helping people sleep better. So I guess you could say the diagnosis I treat is insomnia, but it's not quite that simple as you can imagine. And then the other third of my life is being a healthcare consultant. So I basically have built a reputation as someone who used to run drug rehabs for probably 10 years. I still am involved in the rehab world, in Rehabistan, as I call it. And so I've tried to get out of it full time and just be on the periphery helping improve programs, improve ethics, creating legal, ethical, billable groups, and kind of consulting with the leadership in these organizations to help them run their business better, staff retention, hiring and firing, ethics, navigating state issues, compliance issues, because I've done all of that as an executive in my career so far. So I'm just trying to be of service and try and help rehab the rehabs, if that makes sense. So
I
that's the
love
other
that.
third of my life.
I did some what do they call that? When you work like part-time at a treatment facility that was basically a house with a bunch of people that were in recovery down in Orange County. And it was a little scary to see the inside of that for a little while.
Oh, yeah. It's a mess.
It's a hot mess. That's a whole nother subject. So we probably won't talk about the addiction industry today. But
Yeah,
my
fair
first,
enough.
so now everybody knows who I'm talking to. So my first question for you is, what drew you to the world of psychology in the first place, and especially training other therapists and clinicians?
Yeah, there's a very lengthy story there, but for the sake of time, so we can get to other really good questions, I want to make sure that I don't spend too much time here. So, and I'm always happy to talk more about it. I even did a podcast on my channel at one point about it, so you can watch that too if you want. My life is I grew up in the industry, so I have close and distant family members who are psychiatrists and counselors. My father is an LCSW, and so I just kind of grew up in, therapy land, the world's worst theme park. And so, genuinely speaking, when you're enculturated into the business as a kid and you start reading graduate level textbooks as a teenager, you're like, oh, okay, so I can see how this applies to this, 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 and this. And it became fascinating. And I think, more of a thing oriented person than a people oriented person. So I have always been fascinated by people. And the capacity to like tackle big problems has always been part of my life. I grew up at, Boy Scouts, Eagle Scouts. So I have leadership background. I have civics background. So trying to be of service and use my perspective to try and see people like things, as dehumanizing as that sounds, has allowed me to kind of effectively work with people over the course of my career. And so I treated people like puzzles as a kid and as an adult. And the puzzle got more and more fascinating the more and more I learned, especially about the brain. So I was really fascinated by neuroscience as a kid. And so my opinion has evolved in the last 10 years, especially. But, most of my life, I'm like, why do people struggle with these very severe illnesses like addiction? When the logical answer is very clear, but then the complicated layers of personality and trauma and how drugs actually affect the brain and don't affect the brain and things like that, that puzzle became very fascinating to me. And so in undergrad, I was pre-med and also psychology. And then I saw what my aunt, who's a psychiatrist, what her life was like as a hospital administrator. And that was absolutely miserable. And so I'm like, fuck that. I'm not going to go be a psychiatrist. That is a miserable existence of 15-minute appointments and pill pushing and, backseat driving hospitals and clinics and things like that. So no way. So I went and got my doctorate in clinical psychology because I was hoping I could do more therapy. And then fast forward to year one of grad school, mostly informational, mostly academic. Year two, first year of practicum, bored to tears. Couldn't care less about people's stories, is what I realized.
Oh, ouch.
Because people are things to me to some
What does that
extent.
mean? Like, say more about that.
Yeah. So whether it's because of autism or who the fuck knows what, I don't
I
even
was going
care
to
what the
ask you, are
truth
you on the
is.
spectrum?
I
Because
don't know.
that's like I don't know. Okay.
I don't even know it's true. It could be trendy. Who knows? Like,
Who knows?
whatever it is, whatever the childhood stuff and the personality stuff and the autism stuff, whatever the combination that is, I realized that I can understand people very quickly and easily and complicated layers of a person pretty quickly, but it doesn't get me off. What gets me off is the chess pieces on the chessboard, is the dynamics of things, not the story,
Interesting.
not the emotions about who you are and all that stuff. And admittedly, that is not a very normal therapist position, which is why I found myself in the administrator role pretty quickly in my clinical career because I was so very good at running things and organizing things and budgets and hiring and firing and assessing people for their skills and their not skills. And so in grad school, I realized very quickly, oh, I don't want to do therapy whatsoever.
Was it like the length of a person's story and their explanation of it where you could just shortcut it and be like, boom?
I could certainly shortcut it very easily because there are not as special as people are,
I
and they
know. I
are.
agree with that. Yeah.
There are also a great many similarities among all of us because we're all people and we all have the same capacity to be traumatized. And, there's personality trait differences. And so I do admit we're all different in terms of our temperament and things like that in our culture. But also, being yelled at for year after year after year will traumatize the average person. That's not super
Right.
deep. It's not super profound. It sucks and it's very terrible,
Yeah.
but it's not deep. And so I never cared about deep. It never got me off as a person. What got me off was
Got it.
moving the chess pieces on the chessboard. And so I became more of an educator and an explainer and a TA in grad school. And then the first chance I got to be a professor, I took it. And I did so many public lectures once I graduated and got licensed trying to educate people about things that just became more normal for me. And
Gotcha.
so because I have this more mechanistic view of things, which admittedly has many limitations, which we can talk about, I see things very clearly and consistently and reliably, and I'm probably 10 steps ahead of people when they're talking. That being said, that doesn't mean I'm always right or some narcissistic thing like that. It
Well, I was
just
going to
means
say
that,
you could be a sign of high intelligence and just you are better at macro work than micro. I feel the same way.
correct. Some
Yeah.
people love micro work. They love the story. They love the details. They want to be on the emotional roller coaster ride with you, and I could care less. And so I've tried to basically use what I'm good at for good as opposed to forcing myself to be in a situation where, you want to tell me about your childhood and your trauma and like that is interesting and relevant and I don't care. Right.
Gotcha.
So I don't want to
Yeah.
hurt people, admittedly. And I
Right.
said
It's
this on this
smart.
one
I think
podcast I did.
you removed yourself from something that your energy was not pulling you toward, and good for you for not harming people when that's just not who you are. It's good.
Right.
I love it.
So I had excellent training and supervision. I kind of grew up analytic, and so I could learn to see all the layers of childhood stuff and defense mechanisms and all these things. So I see the complexity of people, and I have respect for it. It just does not interest me as a
Got it.
person. And so I've tried to move my career towards more mechanistic things where I can be more of service, both as a professor and as a mentor and as a consultant.
Yep. I like it. All right. So let's get into the nitty-gritty then.
Yeah,
We both have critiques of the mental health system, and we both have
indeed.
different perspectives because we have different roles and different life experiences and all the things. So the one reason I like your podcast is the average patient could show up and listen to some of these points of view about what makes a good therapist, what makes a good coach, what makes a terrible clinician, what our system is actually like, does it actually help people, all the things. So what would you say are some critiques that you have about the mental health system in its current form?
I mean, this could take hours, but for the
Yeah.
sake of it not being hours, I'll try to summarize as much as possible. I think there's so many problems with the current system, from the funding side of it and how insurance does things and all the denials and appeals and caring about a diagnosis over a conceptualization, right? Like that's a problem, that you have to care about diagnosis more than you care about the conceptualization of who the person actually is and their complexity. So that's a big problem. The fact that it's, there's billable time slots, 90834, 90837. I think they can all fuck all the way off, in my opinion. Because what is the substantial difference between 52 minutes and 53 minutes? I encourage them all to suck all the dicks. And then clearly I have no feelings about
Filter.
it.
Yeah.
Yeah. So there's all of that stuff. CPT code should be eliminated and gotten rid
Because
of.
why?
I think
But because why?
because who the fuck cares if you spent 45 minutes with somebody versus 50 minutes? Why is that, or 53 minutes, excuse me. So what is the world of difference between 45 minutes and 53 minutes? And why are those reimbursed differently? Because that whole hour of my day is burned, whether it's
Right.
45 minutes or 53 minutes. So from like the selfish, like I would like to make money to not be poor side of this, like what is the difference? And then did they get less quality care because it was 45 minutes? Maybe that 45 minutes was more profound and useful than the 53 minutes. So all of that crap, which is just bureaucratic nonsense to make sure the insurance company doesn't spend too much, right? So all that stuff needs to go and disappear tomorrow, preferably. So diagnosis is part of the problem. Billing codes is part of the problem. Smart goals and all these kinds of outcomes based things that don't represent actual psychological change over time is part of the problem. So that's just the insurance side of it, those three things. And then on the conceptualization side of things, like how are people trained side of things, as a professor in graduate psychology, I have much to say. So like I said earlier, I am a more mechanistic person. I'm more interested in how the Rolex works than what you had for dinner. I care more about cars and how they function. It's more fascinating to me than tell me a story about your childhood. And so that's who I am. Most people are not that way. Most people are the opposite. They like the story. The story gets them off emotionally. It allows them to feel engaged and connected and close and safe and all these things. I don't care. So the problem is that we are trying to make the mind a mechanism, and the mind is not a mechanism. I call it the broken Rolex fallacy. I actually talked about this on my podcast.
Yeah, I just heard you. I was going to ask you that next. Go ahead, say it.
Yeah. So this is what I call the broken Rolex fallacy. So, when we think of the brain specifically, which people consider the seat of the mind, whatever, debate later, but when you think of the brain as a computer or a machine, right? Then you misunderstand what the brain actually is, number one, and how the mind actually works, number two. And so most people, including most mental health professionals, psychiatrists, psychologists, counselors, whatever, think that the brain is a machine that you can fix. It's a machine that you can tune better, right? And so that doesn't appear to be true in any way, shape, or form, even though all these companies exist, like Elon Musk's brain thing and all this stuff. So think of it like this. If you think that the average person who is mentally ill has a broken brain, so people are valuable and precious and sacred. So like a Rolex is a fancy watch. And the cool thing about a Rolex is that if you've ever gotten on Instagram and seen these repair videos, you can literally take a 50-year-old watch that was created in 75 and sold in 75, and you could take that same watch that is broken, the glass is broken, the metal is scratched, the gears have stopped working, the spring is not. You can take that and you can ship it off to Switzerland. And Rolex will, at the factory, literally rebuild it from the ground up, and it is beautiful to watch. My lie is it's amazing. I can barely articulate it. But that is what people think therapy and rehab does to people. People think that I'm going to go send my broken son to rehab and he's going to get fixed and put back together correctly, so he's wound correctly, so he functions like a Swiss watch. And that's insanely dehumanizing, number one. And number two, it's not true. It's not accurate, literally, because the brain's not a machine. And so when you walk into therapy or counseling or coaching or rehab with this, my brain is broken, I need to go fix my cognitive distortions thing, which may be helpful, but it's not fixing anything, then you also take an overly simplistic view of who the person is. And the problem is the brain's not a machine, it's an ecosystem. So your brain doesn't have component parts that function and fire perfectly. There is no perfect firing of neurons. There's more reliable and consistent firing, and there's more chaotic and erratic firing. But there's no perfect amount of sodium inside the cell, inside the neuron, and sodium outside the neuron. There's no perfect amount of calcium or magnesium or whatever, because every neuron in the brain, it's Professor Me, it's like every neuron in the brain has different operating dynamics. They don't all function perfectly the same. Each of them functions in an ecosystem kind of way. So like a desert ecosystem is different than a tundra ecosystem, and they need different things to be normal. You can't rain 30 to 300 days a year in the desert. You can rain 10 or 15 days a year, and that's what's useful for that particular ecosystem. And the ecosystem in the desert really usually butts up against like a tundra or a taiga, and that ecosystem interacts with that other ecosystem to keep the desert stable, right? So the mind is just like that. The mind is an ecosystem, and the brain is an ecosystem. It's not a machine. It's not static. It's not like you fix a piece of it and the rest of it functions fine. It's an ecosystem, which means it's dynamic. There's multiple players and pieces and fluid systems that don't, like, it doesn't rain every day. It doesn't snow every day. It's all interactional. It's combinatorial. So the idea that you could fix your brain is like pretending that you could create the perfect amount of rain in the desert. What does that mean?
And the whole industry is kind of built on that. And the way that you even said it, Dr. Lockwood, was kind of like patients believe. But I would say we are led to believe that this is the case. And so this is what I teach my clients. The whole system is built on you being afraid of your own emotion, your own mind, and thinking there's some external force outside that is an expert in that, that's going to help you and fix you. But I don't think patients came to that conclusion just out of the blue. We are acculturated to believe that. You know what I'm saying? In a lot of different ways.
Yeah. Since childhood. Not even when you first see a therapist. It's in school, and teachers are taught this crap, and teachers who know even less are taught this crap, you know?
Yeah. And I do think, like, let's speak to the humanness of it. We don't feel good. Every client I've ever worked with, and, you know, I'm in psych med withdrawal, and people that are hurt by the system who are leaving the system. So we have to throw all of this shit away that has hurt us. And number one is I can't be afraid of my emotion. Number two is I can't run and think 12 sessions at EMDR are going to fix my trauma. It doesn't work like that. It doesn't fucking work like that. And as somebody who is a severe trauma survivor times 5 or 10, like pretty bad shit that could kill people, it lingers. I don't think of that as pathology or that there's something wrong with me. It's like, of course, I am an accumulation of all the events and life experiences and toxins in my body and a reorganization of my own body to try to like regulate itself as an organism. Is there
Mhm.
some expert that's gonna rearrange the decks of a Titanic and, like, try to fix me? I don't want you to. Stay out of my fucking mind. So,
Ye
what
yeah.
you go. Go ahead.
Yeah, no, I mean, I completely agree. It's like the expert's gonna come do something to me, which, you know, there's probably a subpopulation of people who love that and it works for them, right? There's probably people who are very, like, narcissistically organized, and that's exactly what they want. Fair enough. I think the vast majority of people would benefit from an ordinary professional relationship where both parties are interacting with each other with full informed consent, with a full discussion of what is possible and not possible, what is realistic, what is compassionate and not compassionate, what is useful and not useful, which is not a one and done conversation that's done in 5 minutes. It's an ongoing, evolving experience that's negotiated over and over again. And it's a relationship, which means both parties are showing up to do something together. We're not doing something to people, we're doing something with each other, you know?
Yeah. So, if we were to talk about coaching and therapy, I
Yes.
told you right before we started, I have had the most difficult time trying to find a therapist, and I get it that first of all, I've seen behind the curtain, so I know some of the tricks, and I'm a little too smart for them to try to, and I'm just a hard shell to crack because of what
Sure.
I've been through and people that have hurt
Sure.
me.
Sure.
But I'm just gonna say, I'm gonna be completely honest, because I went to Washington University in St. Louis, Brown School of Social Work, and we had a class of 273, mostly white women therapists to be. And I was underwhelmed by the rigor of that program. I remember taking my clinical perspectives class, and the teacher asked us, how many of you have done your own work? And literally 3 people raised their hand out of 100. And I thought to myself at that moment, you can't go deep with someone if you don't know what the fuck you haven't even done that with yourself. And I know that is a contentious point. Thinking of Irving, is it Irving Yalom? How do you say his last name?
Yalom?
Yalom, Irving Yalom,
Yeah.
in his book.
Yeah.
We
Yeah. You
read
can
that
only
too.
go as far as you've gone, kind of thing.
I agree with that as someone who has
Yeah.
gotten lots of therapy and has tried to help people and do my own coaching work and my own inner process and all the things. But in a 2-year program, a clinician in social work or LPC or all the things, I know you guys have like 5 to 8 years PhD, but I'm just underwhelmed by the quality of therapists and the people that can actually do deep work with people that's meaningful. And in the meantime, a lot of people are doing work that is absolutely useless, that has them running in circles, and if anything, creating neuroticism because now they think something's really wrong with me because this isn't working, or they're constantly monitoring their inner state, and that becomes its own kind of narcissism that I'm broken, I need to be fixed. What next program can I go do? And now we've built this whole industry of wellness and mental health, and it's trendy to be going to a therapist and that you have OCD, and everybody in my class would introduce themselves with their diagnoses. It was disgusting. So
Mm.
I have a lot of critique, but what do you think about like informed consent for good therapy? What makes a good therapist? What makes a good coach?
Yeah, I think good is going to be somewhat subjective depending upon who you are, how you're built, and what you're looking for. So you use the word deep a few times in your little spiel there, and I think the challenge that I have with the concept of deep is that not everyone is ready for that, admittedly. So I can tell you over the course of the last 16 years, some people are very interested and very ready for deep. They want to talk about how their personality organization works and how narcissistic they are and how sadistic they are and how vulnerable they feel and how
Mhm.
masochistic they are, and they want to understand the ways in which they show up in the world and how much that relates to how they were organized and what happened to them, but also just kind of where they're from and all these things. And so, like, that's a complicated and very messy and very, like, contextual conversation.
Mhm.
And some people are ready for that. And some people are not ready for that. Some people are terrified of, like, aggression, for instance. All of us have the capacity to be aggressive, and all of us have the desire to hurt people that have hurt us. That's just like breathing. Now, most of us have been socialized to not punch people or hurt people who have hurt us because that's bad and it's bad for relationships and all. It's bad for various reasons. But that doesn't mean that the aggressive instinct is just gone because you've been socialized out of it. It just means you've learned a more useful way of operating in the world, which is a very good thing. I am not advocating that people punch each other because they're upset or they feel hurt. That's bad. I don't agree with that. So to me, finding where the person really is at, discovering in conversation in a professional relationship where the person is at, is important for informed consent. Because a good therapist, in my opinion, will be able to assess, to use a technical word, someone's level of personality function, someone's level of insight and judgment, someone's, and then the complexities that modify that, right? So there's trauma that modifies how insightful we are or are not. There's trauma, there's neglect, there's family of origin dynamics, right? That modify what's okay to do, what's not okay to do. And so there's all these layers that you need to be able to assess to be able to have the appropriate kind of relationship that the person's looking for. And sometimes what the person's looking for is not actually what they need, but it's not up to us necessarily to tell people what to do. Now, that's what something new therapists get wrong all the time. It's like, oh my God, you have to, like in rehab stand, it's like, oh my God, you have to get sober. It's like, sure, that would be a very good idea because fentanyl is dangerous. And I
Right.
agree. And like, this
How does
person
that
might
work?
not want to be sober,
Right.
you know?
Tell
This
somebody to get
person
sober
might,
that doesn't want to. Yeah.
and this person might just hate themselves. That happens. There are people walking around who smile, look good, happy, whatever. They hate themselves. Whether they have an addiction or PTSD or whatever. Some people are just walking around right now with all sorts of self-hatred that they don't want to see, right? And so people are very, very complicated. And so I think the best therapists are the ones who have respect and reverence for how complicated we are. And they also are aware of their own stuff. I think this is another quality of good therapists. I think good therapists and coaches and counselors and pastors even are people who are aware of their desire to be perfect, or their desire to be idealizable, or their desire to be safe, or their desire to be unaffected, or whatever it is. It can be any number of things, any combination of things. And so sometimes that's called countertransference, what have you. But being aware of our stuff, I think, is extremely important if you're in one of the helping professions, if you're a nurse or a counselor or a coach or doctor, or whatever, because that will push you and pull you while you're sitting across from somebody. And sometimes it'll push and pull you in a useful way, useful for that particular person in that scenario. And sometimes it'll push and pull you in a very counterproductive way that's more
Totally.
self-gratifying than useful for the patient. So I think those are two very important qualities for good clinicians. I think a third important quality is patience. To me, it seems like, and this could just be my convenient sample of a life being a professor, but I think no matter what your background and how you're built, a lot of people who come to this work are not very patient. They would like for other people's suffering to disappear tomorrow.
Hmm.
And I obviously sympathize with that because clearly you'd be an inhuman robot if you're like, it's great, I'm happy that you're suffering. This is good. Please continue to suffer. And or sadistic even, right? I believe that the patience required to do good clinical work of whatever kind is sorely missing, because just because like I said earlier, I can see all sorts of stuff super quickly.
Yeah.
Seeing it is different than communicating it effectively. So seeing it effectively, clearly, consistently, correctly, communicating it effectively, and then negotiating what we want to do with it.
And then integrating it on the patient's end. That is a very long process.
How long does that take? Who knows?
Whew,
Nobody knows.
who knows?
It's that Nate Bargatze meme. Nobody knows, because nobody knows. Like the psychoanalysts don't know. Nobody knows.
Yeah, but in the modern therapy climate, I think it's very outcome driven, evidence based, brief intervention, get them in and get them out. Even at the VA hospitals, there was like a memo going around about they started limiting therapy sessions, and they're like, 10 sessions or less, got to get it moving because there's too many, and there's this drive that everybody wants therapy. I think it's good that people want to work on themselves. They want to feel better.
Yeah.
They want to improve
Yeah.
their inner
Yeah.
life. That's a good thing. But I don't think I've done a lot of work on my own. And then I pull in clinicians when I can find a good one and when I feel safe with them. And it can take me a year to even understand what they said to me a year ago. Like, what did that mean? Oh, now I get it, yeah. So now let's move to diagnosis. This is a big one. And this is probably surprising, but I want to say this during our podcast, that when I started coaching, I had learned all this mental health. I had to take differential diagnosis. I had to learn how to diagnose. And it was one of the reasons I did not want to become licensed, because I felt I can't ethically do that when I think that some of these people that I'm working with have socioeconomic problems that are not in their minds. And it just felt so bad to me that I took an internship where I didn't have to diagnose. And it was in community mental health with immigrants, refugees, and asylum seekers in the United States, and Spanish-speaking people that we had interpreters with. And so every time I would meet one of these people, or even the Americans I worked with, I would see racism so clearly. And they were upset about that. And I was like, I can't give this person a diagnosis of PTSD because somebody at their work is an asshole. Like, I just can't do that. I can't feel good about that. But here's the thing that was interesting about working in deprescribing is that I never expected to see people walk away from their diagnoses, like completely have nothing. They don't want nothing to do with it. They will they will stop the medical language. They might refer to it like my OCD is flaring, but they're working on it. They're not recognizing it as this medical entity that they need to go fix.
Yeah.
Because they tried that and it hurt them. Yeah. So I've only had 3 people in 4.5 years that have kind of clung to their diagnosis, or, they're not ready to let it go, or they believe in it, or it fits for them. But everybody else is walking away, which has blown me away. And it wasn't of my doing. They came to their own conclusion of that. What do you think about that?
Yeah, I think diagnosis can be useful, and I think it can be harmful. And so to me, that's that centrist thing you were talking about earlier. I believe, genuinely speaking, there are valid cases of diagnoses that if we didn't have them, we might misunderstand the person. So just to give a couple examples. Yeah. So if I see somebody walking down the street, I worked with this guy named Robert years ago when I was an intern at a psych hospital. So Robert is many things, but he fits a variety of Los Angeles stereotypes. He's an African-American male. He was younger at the time. He was floridly psychotic before he was brought to the psych hospital. He was also intoxicated on THC, methamphetamine, and I think alcohol, which is a pretty standard cocktail for people who are homeless here in Los Angeles, or at least it was for years. And so Robert fit a stereotype. And lo and behold, he got arrested. He got brought to the psych hospital I was an intern at. So what's Robert's diagnosis? Because he had drugs in his system, so you can't, as you know, you can't really diagnose somebody with schizophrenia when they're actively intoxicated, because it could just be the drugs, right? He also had a truckload of childhood trauma. Just he's abused, and he was sexually assaulted, and all these things. And so maybe PTSD is the correct diagnosis, but currently he's talking to himself, and he's floridly psychotic and blunted affect and hallucinating. So I like Robert's case for this conversation because he's a success story, which is wild. He just had everything against him. He had the racism of Los Angeles against him, and the healthcare system and the police system. He had being gay and all these things against him in terms of like variables of oppression and layers of systemic, all that stuff. And here's the thing, is he succeeded. And he succeeded because he did what he needed to do to work through the systems he was stuck in, with me for about 9 months and other systems. So did he have a diagnosis of substance-induced psychotic disorder at the time that I saw him? Sure. I think the psychiatrist in the psych hospital gave him a schizophrenia diagnosis because he had a reported history of multiple episodes of hallucinations and things like that. But still, did he have that diagnosis at the time? Sure. Did he have the diagnosis of a substance use disorder? Yeah, he had 4 different substance use disorder diagnoses because he overused meth for years and alcohol and THC and all these things. Okay, so he had a variety of diagnoses, and they all made perfect sense at the time when I was seeing him, right? Now, when he got to the outpatient clinic, because the psych hospital is connected to an outpatient clinic, and I saw him for an extra 6 months to do therapy with him, psychosis abated. He took the meds he needed to take, it kept him hallucination free, and he was in recovery. He was sober, he was going to meetings, everything was good, which is great. And he started to work through some of his trauma with me, which was great. Now, it was only 6 months, so that's not forever, but he started the process of integrating and healing and things like that. And so by the time I left him, I don't think I would have the diagnosis of schizophrenia on his chart because he was medication compliant. He wasn't hearing voices. He wasn't having negative symptoms of schizophrenia. So he was very functional. He was a quote unquote normal person by the time we were done. He just happened to be on meds to keep the voices from coming. So at the time, were the diagnoses useful? I think so, because it gave us ideas about what meds might be helpful and what types of therapy things to try. Do I think that's true for the vast majority of people that come to therapy? Probably not.
I agree.
And the reason I say probably not is because many people that come to therapy with a diagnosis of GAD or PTSD or whatever it is, it's probably true that they kind of loosely meet the criteria. But for most people, that diagnosis never appears to change or evolve. And so you're just forever with PTSD. And the diagnosis becomes part of your identity, which, at least with my work with Robert, that was not our approach to things. I think he believed at the time that he had schizophrenia, and that was what was motivating him to stay on his meds. I can't tell you whether or not he stayed on his meds because it was like 10 plus years ago. But like at the time, it was the safest course of action, and it helped him get sober and helped him build his life again and get hired, get a husband and all these things. And so like it worked at the time. He's a success story because he got his life back and he got to be a functional person again. Is that what happens to the average person in therapy? I doubt it. I think the average person that goes to therapy gets a label, and that label becomes them, and that becomes the thing they focus on. And that makes no sense to me.
But let me push back on that. Is it by way of your treatment that fixed Robert, or was it by way of Robert's growing out of old habits and things and patterns that he had done? Is it Robert's sense of humanity that helped him through that? Because I could think of 8 million different things that could have happened. Like when people grow out of addiction, for instance. Addiction is not a permanent condition or a brain disease for everybody. Some people grow out of it.
Some people don't have an addiction, they have a substance dependence, which is not the same thing.
Maybe, but that feels like a little bit of an okie doke to me. Let me tell you why. It's like, Angie, the people that can get off meds are just the worried well. Okay, but you guys decide that like after these people have taken courses of treatment and listened to everything that you had to say and were compliant patients, and you kept telling them that they were bipolar. So now all of a sudden it's like the patient's fault that like, oh, they were just the worried well. Those aren't the real mental ill people. The real mentally ill can't get off their meds.
I think we're talking about maybe a few different things at
It
once. So let me
is. It's
see.
like 5 different ideas at once. But
Yeah.
like, I guess one is by what mechanism did Robert actually heal versus the way that we are dishonest about diagnosis and treatment for people that perhaps don't need it because we're capturing way too many people in the mental health system.
Yeah, I think those are two separate but
Two
related
different
things.
things.
So
Mhm.
I think Robert definitely healed to some degree, whatever degree he actually did heal. Again, admitting I don't know what happened after our time together, but in the time that we spent together, I think he healed because of dozens of things. I
Right.
think he healed because he got back into a church again, and he loved church as a kid. I think he healed because he stayed on his meds long enough to be hallucination free so he didn't end up back on the street and getting high again. I think he healed because he stopped using meth. Because I don't know about
that'll
you,
help.
but I don't know many people who do
I
better
don't know
with meth in their
functional.
life.
Yeah, functional meth
Yeah.
addicts. I don't know any.
Though I once worked with a young guy who's like, I want to use meth like a gentleman. I'm like, God bless you,
That's
sir.
doesn't happen.
It doesn't appear to happen. Yeah. So if it does, if someone out there has, let me know.
Wait, it's called Adderall. Wait.
Yeah. Yeah, that's a conversation.
Da-dum-ching.
We could certainly go there for sure. But like, I think he literally healed for dozens of reasons. I think our therapy was helpful, and we started to like unpack the trauma that he had and help him feel more empowered as a person. That I don't think is the end of the story. I think the story is he did some work with me while he was in our IOP and stuff. I think he went to meetings. I think he had a sense of spirituality that mattered to him. I think he got into a church that mattered to him. I think he eventually found a relationship that mattered to him and he started working again. I think it's all of these things.
Other things. Yeah.
Yeah. And so my hope for everyone I ever see as a professional is that they do all of the things, and so therapy can be a part of that for some people. However, as you said, your humanity is far more complicated than just tell me about your core negative beliefs and how that relates to your depression. It's like, that's probably useful. That is not the end of the story. That's just the tip of the iceberg for the vast majority of people that show up in a therapy office. And some people just become hyper-focused on fixing their symptoms, which I vehemently disagree with as a person. Now, the question of overdiagnosis, right? So let's take the addiction thing, because I love this conversation, because I've spent all of my life working in rehabs, basically, and to this day. So the DSM has 3 levels of a substance use disorder: mild, moderate, and severe, based upon how many symptoms you present with in the last year. Maybe useful, maybe not. Most people, epidemiologically, the vast majority of people diagnosed with a mild substance use disorder never get treatment, never go to therapy, never take meds, and they naturally stop on their own. The vast, like 90% of people with a mild substance use disorder never need therapy, meds, rehab, whatever, because they touch the stove in some particular way and they change their behavior.
Mm-hmm.
So is that even a real diagnosis? In my opinion, I don't know why it's in the book, honestly. But DSM-5-TR, moderate or severe substance use disorder, has a very different trajectory than mild, right? And so we have all sorts of literature that shows if you have a moderate substance use disorder, you respond very well to therapy usually. You change your habits, and usually you can either continue using drugs in a more modified way, or you become close to abstinent, basically. You decrease your use. People with a severe substance use disorder, they have a very different trajectory. So there's 2 flavors of people with a diagnostically severe substance use disorder. There are addicts, and then there are people that are dependent. So people who experience just dependence, which can happen, you break your leg, you go get Oxy, you have an underlying trauma you haven't addressed with, and you're using the Oxy to cope. That happens. That can be substance dependence. That is a different group of people than the people we call addicts, in my opinion. And we even have some research, some fMRI research, that convinces me in the direction, or pushes me in the direction, that the addiction brain is not the same thing as a dependent brain. Now, we need probably decades more research to actually confirm that that's a fair split. There may even be some overlap. Who knows? But the kind of person that ends up in AA is a different creature than the kind of person that just needs to overcome withdrawals and cope better and things like that. So I would say that if you treat someone with substance dependence like an addict, you're going to make them worse. And if you treat somebody like an addict, like a mild substance use disorder, you're going to enable them. So
good point.
Are those, because addiction is not even a diagnosis. It's a cultural label that we have adopted in clinical psychology and psychiatry to describe the severe version of the DSM-5-TR severe substance use disorder. So it's the severest of the severe, the top 5% of people diagnosed with the severe version, And so that's a different group of people, which I would never want to treat with just therapy or anything like that.
Got it. Thank you. Okay, so let me think. Is there anything else I want to ask you about, like overdiagnosis? I don't know. I just think it's a little cruel because, again, our perspectives are a little different. But the people that I work with believed in the system, believed in diagnosis, did what they were told, took their medicine as directed, did not abuse it, went to therapy. And at some point, it hurt them. And usually they started getting really bad side effects, or their doctor tapered them off too fast, and it completely destabilized their entire lives. And the way that psychiatry, and most therapists can't even spot it. They're not trained in this. Okay. So I work with these people that have been disenfranchised and it's a lot of betrayal and mistrust, and they will never go back to a therapist or a psychiatrist again because the system kind of refuses to see that this is a problem. So I don't know. I just wanted to say that out loud, I guess. But I just feel like it's unfair to tell people they're sick when they're not, to tell them to take medicine that makes them sick, and then to abandon them when they actually are sick.
I agree. And I always wonder about the specifics of each of these cases because as much as I think there are many people in our profession who are very, very ill people themselves, narcissists and sadists and different types of personality combinations who probably hurt people unintentionally or unconsciously intentionally. I also believe in Hanlon's razor very strongly. That I believe that there is just an entire world of ordinary ignorance that I wish we could avoid, but I think part of being a regular person, unfortunately, is, ignorance. Like that's
Yeah.
Hanlon's razor. Attribute not to malice that which you can attribute
Yeah.
to
It's ignorance.
ignorance.
Right.
Yeah, and I think that the vast majority of professionals have some substantial degree of ignorance that I don't know. I don't know what a reasonable standard is for most people who are in the profession because my years being a professor has showed me that the caliber of people that come into the profession is all over the map, you know? And
Yeah, I agree.
so we could change screening and admission standards, but then you would make less money as an institution. So that's a possibility. That's a problem. The other problem is that if you really have grace for people, they might change, right? Like the version of me that you're talking to right now is 1,000 times better, not even exaggerating, than the version of me that you would have met my first and second year in grad school.
Me too.
I was a
Yeah.
miserable piece of shit in the first and second year of grad
Me
school.
too, actually. Me too.
And so, like, one thing I try to remember as a professor is like, God, who knows what their journey is like? Maybe they're like me and they're going to get better.
I know,
Right?
but you're being so kind because I see this as willfully not in the curriculum at a mass scale. It's not.
I mean,
Okay,
medication harms is, yeah.
I took psychopharmacology for social workers. Okay, the damn professor who is a 35-year pharmacist at a major hospital network in St. Louis literally told me, Angie, you could have taught the class on benzos and antidepressants. You know more about them than I do.
Which
You're
is
going to
sad.
tell me that's because of incompetence or ignorance? No, that is mass. I'm not trying to sound like a conspiracy theorist. It's true. It's not in the training. And I believe to this day, it's more willful blindness than it is ignorance because we have my dean of mental health literally cornered me and said, Angie, if you think you're going to work in trauma, you need to take prolonged exposure therapy. You're never going to be a clinician. And then when I told him I wanted to help people that were hurt by the system, he laughed at me. He fucking laughed at me. Like it's funny.
I believe it.
Okay,
Yeah.
it's not funny. And
Yeah.
so I just see it just hurts me because every day I carry these stories of people that have been hurt and they are just well-meaning patients going to well-meaning docs. But you can't tell me one of our core ethics is to just meet your patient where they are and to like listen to their experience and try to believe them. And we don't even have clinicians that can do that. That's a basic skill.
Yeah, I mean,
I'm sorry, I'm mad about it.
Yeah, I think being mad about it's perfectly understandable, and
Does
that's
nothing
why
though.
I
My anger
created my
does nothing.
podcast. But that's why we have this podcast, and that's why we're trying to get the word out about what competence looks like. And I think going back to your professor's example, I teach psychopharmacology for my master's level students, and so I'm extremely acutely aware of adverse effects and how these drugs work and don't work. And if you follow me on Twitter, you'll see me interacting with psychiatrists and talking about very complicated, fine-grained mechanisms of these medications. And I care about that. It will never change how patients understand meds, but I care about that because if I am not aware enough when I'm a professor, then I will mislead people, right? So I care about that. And so I talk about adverse effects. I talk about post SSRI sexual dysfunction. I talk about all these things in my classes. I talk about tolerance and dependence. I talk about the difference between tolerance and dependence versus the brain adapting to the medications, because those aren't technically the same thing. And so when we understand the specifics, we can help people understand their experience better, which is my goal, right? Better concepts allows us to understand our experience better. And that's why I teach psychopharm and I love it. And I'm finishing my last week of the semester next week. So like There are those of us out there that are trying to do the right thing,
I know.
and I don't know how many there are, honestly. So I would love to be more optimistic about this in particular, but I know I am not the only one. And the people that I get to argue with on Twitter who are also psychiatrists and stuff, they're interested like I am. Like Nicholas Badre is a
I
psychiatrist.
love
I
him.
argue with
Yeah.
Michael Osterith, who people don't like as much, but
Yeah.
he's at least willing to talk about the specific mechanisms, whereas other people just hide behind you don't understand or whatever. But like I can come back at people as a non-psychiatrist, as a psychologist, and be like, this is what I know. Let's talk about how Lexapro is actually built, which happened this week, right? So like I can do that, and I know I'm not the only one who can do that. I don't think there are many people who can do that, but I am not smart enough to be the only one. I don't have some special level of intelligence. I'm just nerdy enough and disagreeable enough that I want to be right. That's it. It's a beautiful combination because it pushes me to push myself beyond what I think I know into things that I probably shouldn't know and don't need to know. And like, there are other people like me who are nerds who are into this stuff out there. There's just not a lot, unfortunately. I lost you for some reason.
Wait,
Oh,
sometimes my
there we
microphone.
go.
There it is. It's my microphone.
Yeah.
I wasn't expecting the conversation to go in this direction. I promise to get back on the topics that we discussed, but I do have a
Yeah.
question. I do have a
Yeah.
question really quick because it is about this, and my audience would want to know what you think about this. Okay. I'm just going to be very generalized when I ask this question, but in
Okay.
general, and I'm including myself in this because this is also my personal lived experience. We go on medication expecting it to help, but the form that helps, it does change our personality. It can change our mood. It can change our thoughts. It can change our ability to express emotion. There is a numbing effect in a lot of it. Okay. But what we don't understand as patients is doctors know that, therapists know that. So how is it so unbelievable that when a person comes off said medication like Lexapro, their emotions and things sort of pendulum swing, which to me is a basic idea of psychopharmacology. And so there's this withdrawal effect. There's a rebound effect. It's not all relapse. But why do you think it's so hard for the average clinician to even believe that? Because these doctors are incredible, thinking that a person is on Lexapro for 30 years and they're supposed to come off and be fine in a month. That is ridiculous. That doesn't even make sense.
That makes no sense to me. I think this goes back to that Hanlon quote. So Hanlon's razor, ignorance, attribute not to malice that which you can attribute to ignorance. I think that this doesn't sound super optimistic, and I apologize. The people who are in this profession are not that smart.
I would agree with you.
The
I just
average
would.
physician,
Yeah.
the average physician is rather average. They might have an IQ of 110, 120, 130, whatever. They might be on paper good at math or something like that. Maybe they did good in organic chemistry. Maybe not. I don't know, honestly. So it's not about their literal capacity to be intelligent. It's just that they don't use their intelligence because they don't need to. Because these standards are about willful ignorance in the sense that you're not required to think as much because that's not your job. In most, like, because again, most people get their psych meds from their primary care doctor. Most people are not getting them from a psych nurse or a psychiatrist. And so your PCP knows next to nothing. I would say that of all the primary care doctors in the United States, narcissistic, arrogant claim, I probably know more than 98% of them
I think I
about
do,
what
and I
these
live in a
medications
van.
are.
Yeah.
Yeah. I think so.
Jesus.
I
Scary.
believe that they don't, because they're not required. Like, I can't imagine being a primary care doctor and being able to know every little intricacy of every little thing that you prescribe. That seems like an inhuman standard. So the standard is not you're so perfectly smart and knowledgeable. Excuse me. Like, I don't think that's normal. And so I think there's an ordinary amount of ignorance, whether it's willful or not, that produces harm. And I think that is part of the process. Now, the idea of getting off of medications, I think if you're a primary care doctor and you have 15 minutes with somebody and they're like, I want to get off these meds, go to AI. Go find the potential risks of getting off these meds. There's a formula you can do to see what the taper could look like, for instance. So hyperbolic tapering, blah, 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 blah. Like there's so many things you can do that don't require hours and hours of research. Right. So I think that is laziness, and I have no patience for that. I do have patience for the fact that ordinary ignorance makes sense because it seems like a somewhat unreasonable standard to expect people to fully understand these things, because most psychiatrists don't even fully understand these things. They
Yeah.
understand fairly well enough, but not like super far, psychopharm micro level. They don't.
It
And
seems that
I think,
they just don't even understand the basic mechanics of a drug. And then when somebody comes off, what do you think is going to happen, especially if you take them off fast? It's just like, to me, it's just, you're not even humble about how the human body works. Like you were saying about it earlier, about how everything is orchestrated together, everything's in relationship. And I think about, from Medicating Normal, Peter Gercha has a quote where he says, like, how ignorant are we that we just think, oh, I'm just going to go in here on the side of dopamine and tweak it a little bit, and it doesn't have like a downstream effect. Like, it's just so dumb to me. I don't know. Sorry. Just,
that's the ecosystem
yeah.
thinking. Yeah, that's the broken Rolex fallacy. We can just fix this serotonin problem or dopamine problem or whatever. Yeah. It doesn't work. It doesn't work. What it does is it stabilizes a mechanism.
Mhm.
Right? And so it works because it stabilizes things. It doesn't work because...
Well, I think it creates a change. And when you have a change in the system has to update that. And that's the process of reaching homeostasis again. So when you introduce a chemical, the body's like, oh shit, what is that? I'm supposed to do something here. And people interpret that as, it helped me. Okay, it probably did. But it's not fixing the site of a mental illness, though.
No, there are no psychiatric medications that fix mental illness, because fix implies broken.
Exactly.
And I'm not about that.
No, we're not Rolexes. Okay.
Nope.
Thank you very much. So let's do the last question, and then I ask all my guests the same question at the very end. But
okay,
I find Twitter to be very triggering and infuriating. And actually, I have spent less and less time on there because, honestly, I get so pissed off. I want to throw my phone, because it's just a bunch of patients. No offense to patients, but you guys, the more crazy you sound on Twitter, the more they believe we're crazy. Okay, you're not helping us. And then these damn psychiatrists and therapists are so egotistical. They just think these stupid, crazy patients, block, and we're getting nowhere. And to me, it's like, I just can't do it anymore. I can't. I follow you and Nick Tabor and a few other people, Nicholas Badre, Mark Horowitz. That's about it. And everybody else, I'm like, fuck off. I can't listen to this shit anymore. And you're arguing with each other, and you just, you sound like you're right, and nobody's actually listening. So what do you think about therapy Twitter, psych Twitter? Is the discourse helping? Is it hurting us? What do you think about it? What's your opinion of Twitter or X?
My opinion of... I'm very grateful for Twitter/X, because I've met lots of cool people, yourself included. And I think the challenge that we face, like you're saying, is like, what is our relationship with it? You know what I mean? Because I have some periods where I'm like, I'm going to take it seriously. I'm going to argue about something. Like I got into a back and forth with Nicholas Badre a couple of days ago about Lexapro. But like, that was 5 minutes of my morning. It wasn't like an hour where I had to be right or something. It was just like, let's be real, And that was fun, and it was productive. And some things were said that I think clarified the reality of Lexapro compared to other SSRIs. And so that was useful, and people can go see that exchange and maybe learn something, perhaps.
I'll tag it below, by the way. Yeah.
I think it's great. Now, that being said, is that my life or something? No, my approach is, if I have a 5-minute break, if I want to go screw around and joke around with people, okay, that's cool. That's time well spent, in my opinion, because you just never know what you're going to learn, in my opinion, personally. And you never know who you're going to meet, because like, I didn't know you for real a year ago, And Nicholas, I have talked with on and off. But so there's like lots of really interesting people like Nick Tabor and all these other folks who I think add something useful to the conversation. And my hope is that more people chime in. I know that it's a mess, and sometimes the mess is one of our faults. And I'm okay with that. Like, I'm okay with the fact that sometimes I screw up. That being said, it's not my goal. My goal is not to make it a bigger mess. My goal is just to add an opinion and see if it reaches people and if it's useful for people. And sometimes it's not useful.
Yeah.
That's okay. Sometimes people disagree, and I love that, and I have no problem with that, because disagreement is where, like you said earlier, that's where growth happens. That's where news shows up, usually. Now, sometimes, as you said, new does not show up in online disagreements. But I think you have to go through that in order to get to the new at some point.
I
I
keep
don't think it's
giggling.
always going to work out well, you know?
Yeah, I keep giggling to myself because one time I was on there and I do really try to discourse with Tyler Black, but he just gets under my skin like nobody else. And one day I just called him a turd. I'm like, Tyler, you're a turd.
He's
And
not a
then
turd.
I had to pull up my text messages because I couldn't remember what I called him. And then somebody texted me and said, the best thing about Twitter today was that you called Tyler Black a turd.
Ridiculous.
I know that made me feel better though. But we still go back and forth. But do I think he's listening to me and believing me? No, not really. It's entertainment, but it's triggering entertainment.
Yeah,
I
I
don't know.
think he has
I
since
should be
blocked me
better.
because he believes I'm not very compassionate or anything like that.
Oh
But
boy, that's
I
wrong.
believe I think it's just, I push the correct button at the correct time. And
Yeah.
so I think he's useful. I think a lot of people can't stand him or hate him, but I think he's extremely useful because he has a very precise opinion, even if he
Mhm.
doesn't always speak precisely, which I have a lot of respect for. So he's not just talking out of his ass, which I appreciate, because there are many psychiatrists online who just talk
Well, they
straight out
do.
of their ass.
True.
Whereas he at least tries to live in the data, which seems to be missing in the profession, interestingly enough. So
Mhm.
him and Nicholas Baudry both like to live in the data, which is interesting. Whereas Tyler is more institutionally favored and Nicholas is kind of in the middle like I am. And I think that he's useful. I don't agree with him half the time probably, but I think he's useful. And I want his voice to be valuable for what it's valuable for. And I never want him to feel like he should leave the online world, because people like him are the appropriate foil for the people who just have the worst takes in the anti-psychiatry world, who just believe absurd myths about life.
Yeah.
So,
I mean, I appreciate him because he sheds a light on what some psychiatrists think, and
oh yeah,
I get off on trying to understand how people think.
yeah,
Like, what perspective is he coming from, and how would I argue to maybe crack some light into that perspective? But in general, I don't feel effective, but I still do it. But it's a larger thing. I think I'm just frustrated in general, just with social media, that we are constantly chasing an algorithm and we have to post this classy, jazzy comments. And I'm just exhausted by that. And I'm just I don't care enough to be an influencer. I have shit to do,
uh,
I have
yeah,
shit to do.
yeah, yeah.
Anyway, okay. So I think I could talk to you for another hour, but I'm going to end on, do you have anything you want to say or anything?
No,
I don't know.
yeah, yeah. No, well, this has been
Anything we
great.
missed?
No, no, this has been great.
Okay. So here's my last question that I ask every person that I talk to. And for you, I think it would be, what is your hope for the average person that's watching, that's thinking about mental health, that has critical of it, that is maybe questioning it, that wants good care? What could be some hope that you could bring them?
Hope. I think there's a lot of hope to have, in my opinion. But despite the things that I've said today, I actually genuinely do feel optimistic about the field more broadly, because of literally what you just said about all the fighting on Twitter. The fact that there's this much fighting is extremely inspiring to me, because there was a time, especially earlier, a decade ago even, when the fighting was very minimal. People weren't arguing about meds. They weren't arguing about what this diagnosis actually means or doesn't mean. And now that's happening all the time. So that's very inspiring to me, because the more the argument continues and the louder it gets, the more we have to do something with it. So that feels good to me. And if you're out there and you're very skeptical of the profession, that's perfectly fine. I think skepticism is useful. The question is, up to what point? Because in order for anyone to change, we have to be able to trust people. So if your skepticism is drastically interfering with your ability to trust people, then it doesn't matter if you're anti-psychiatry, pro-psychiatry. If you're too skeptical, you just end up in tinfoil hat land and isolated. And what I don't want for any human being is I don't want anyone to be isolated. So even a mediocre therapist, as much as I rail against this, but even a mediocre therapist can help you because that's a relationship where someone is interested in your well-being and hopefully unbiased enough, even if they are mediocre, to give you a place to express yourself and explore yourself. And so I want people to get whatever help they think they need and understand that it's not a linear process and that maybe the first therapist or the third therapist you interview is not going to be a good fit. That's okay. It's a relationship. It's an investment of time, energy, and money. And so I think taking that relationship seriously and making sure there's professional boundaries is important. And finding that right fit can take time. So I hope people have patience with themselves and they don't have the pressure to fix something right now because there's nothing to fix right now. Even if you're drastically suffering, there's nothing to fix right now, which can sound cruel, but it's literally true. And so my hope for people is that they're patient and they see a case for optimism.
I love that message. I really do. And I do, just to piggyback on that, like, I know a lot of my clients are very hurt, betrayed, feel like they can't trust people. But I want to tell you, it has taken some courage to go meet healers in many forms to kind of rebuild that trust, because there are good people out there. I think you're one of
Yeah,
them. You know, even if you're not interested in me as in my story, I still would drink a Celsius. You know, you can drink a Celsius, I'll drink my water. But
fair
I would
enough.
still hang out and have a coffee with you, and I would find some benefit from that. So I like your message that, like, not all hope is lost. Even though you've been hurt, there are still safe people out there to express yourself with that can be witnesses to your suffering, whatever that looks like. I do like that.
Agree. Agree.
So we do agree on stuff. See?
See?
I thought we were going to fight. What happened? It's
Not
fine.
much fighting today.
There's nothing to fight. All right. I love it. Okay. Thank you, everybody, for joining us. You can leave a comment below. I'm sure Dr. Lockwood will come back and check it out. Be sure to follow him. Where can they follow you? On YouTube and X?
Yeah, so I'm on YouTube and X, and so my YouTube channel is called the Psychology Checkup, and my weekly podcast on Saturdays is called Unshrink Me, and that's at 3 o'clock Pacific usually. And then on X, my handle is at Alobha Patrick, at ALOBHAPATRICK.
Awesome. All right, Dr. Lockwood, thank you for being with me today and having this
Thank you.
cool conversation. And thank you, everybody, for joining us. And we will see you later. Stop.